Very good afternoon, everyone. It gives me immense pleasure to welcome all of you for the second academic hour session for this year of the continuing professional development lecture series organized by the Clinical Society of Base Hospital Mahiyanganaya together with the branch union of the GMOA. So today's lecture will be on how OMFs help your patients, an area that is quite new in this setting, and it will be conducted by our very own consultant, oral and maxillofacial surgeon of Base Hospital Mahiyanganaya, Dr. Sankalpa Gamage. I now cordially invite Dr. Ruwan Wickramasinghe to invite our speaker for the day.
Good afternoon, everyone, and welcome to the second session of the academic cover for 2026. It is an honor to introduce our speaker for today's session. Dr. Sankalpa Gamage is recently joined with Mahiyanganaya Hospital. I think it's a few months ago. This is a little bit a new topic because it's a little new area we are touching today. The face and the jaw, everything between. Dr. Sankalpa graduated from the Peradeniya University dental faculty, and then he completed her MD from Postgraduate Institute of Sri Lanka, Colombo, and he finished his foreign training at Edinburgh, Scotland. And after returning to Sri Lanka, he joined. After returning to Sri Lanka, he joined the Mahiyanganaya Hospital as a, I think, first OMF surgeon in our history, maybe, probably, as far as I remember. And I would like to invite Dr. Sankalpa Gamage to continue the session. This topic, the face, the jaw, and everything between. How OMF can help for our other field in the clinical practice. Thank you.
Thank you, Mahiyanganaya Clinical Society, and thank you everyone for being here. So, face, the jaws, and everything between. So, why this topic? As Dr. Ruwan mentioned, so this is a new specialty to this hospital, and we are trying to establish a new unit in this hospital with immense difficulties. Nowadays, there's a consultant oral and maxillofacial surgeon without any medical officers, without a place to work, obviously without anesthetist. So it's me, and thanks to the dental doctors in the dental OPD, I'm doing something with nothing. That's why I'm trying to tell you all what we do, so what you can get from us. So that's the idea of this, and I'm Sankalpa Gamage. Right. So what is OMFS? So according to the description, or according to the definition, it is defined as the bridge between the medicine and dentistry. So, you know, all the other dental specialties, if you talk about dentistry, it is all about teeth. So if it is beyond teeth, obviously, and to communicate with the other medical specialties, mostly it is OMFS. So in Europe, in order to become a max-fac surgeon or a maxillofacial surgeon, you need to have dual qualifications. You need to have a dental degree as well as a medical degree. Then only you can become a max-fac surgeon. In Asia and Southeast Asia mostly, you can become a max-fac surgeon with a dental degree. In Sri Lanka, the same case, and India, Pakistan, Bangladesh, all the case. And in some of the European countries, it is a medical specialty. They just, with the medical specialization, with limited exposure to dentistry, they can become. So in Sri Lanka, we do undergo like 2 years of medical training in medicine, general surgery, and all other specialties to become a max-fac surgeon. So oral maxillofacial, as the specialty term, it is about mouth, jaws, face, and neck. Okay, so it is a regional speciality. Is it stuck? All right. So it is a regional speciality, as the name suggests. So in this region, we do most of the things. So in this region, we become trauma surgeons. In this region, we become cleft surgeons if there's a cleft. And in this region, we become oncological surgeons when there's cancer. So in this region, we become reconstructive surgeons when there's a reconstructive need. And we become plastic surgeons if there's any plastic need. And vascular surgeons, obviously the oral cavity, we become oral surgeons. And up to some extent, we practice medicine. So we become physicians as well. Okay. So just to tell you about something about being trauma surgeons. As you all know, head and neck region is composed of lots of bone. So we have the mandible, maxilla, zygoma, nasal bones, orbit, we have the frontal bones. So when there's a trauma, obviously head impact, and they'll have fractures. So we manage mandible fractures, zygoma fractures, leaf-out fractures like left-out 1, 2, 3, and we manage orbital floor fractures, and we manage frontal bone fractures and nasoethmoidal orbital fractures and everything. Right, little bit academic. So if we look at the epidemiological data in Sri Lanka, the most common facial bone fracture is the mandible fracture. Not like in the West. In the West it is the zygoma fracture, but in Sri Lanka it is the mandible fracture. The second common fracture is the zygoma fracture in Sri Lanka. And the nasal bone fracture is also common, as you know, but for some reason it is underreported. Maybe it is due to the minor nature of the injury, the patients or the people not participating or not coming into the hospitals. So the common causes are road traffic accidents and the interpersonal violence. So some message to the, especially to the medical officers or the doctors working in A&Es and the surgical departments. So what to look for when there's a head and neck injury. So in obviously like these photos, you will see patients with bruises, some asymmetries. So always look for asymmetry in the face. So if there's a fracture, normally there's asymmetry. And look for these kind of swellings like bilateral periorbital ecchymosis. So we call it raccoon eyes, which is a classic sign of leaf-out fractures. And look for the eye position. So obviously if there's an orbital fracture or zygoma fracture, their pupillary levels can be different. So 2 levels of pupils. And you will feel, when you palpate, you will feel tenderness over the fractured bones, and you will feel steps over fractured bones. So look for steps. If there's a fracture step, normally it's a fracture, so call us. And you might feel crepitations. And look for the orbit, look for the eye. So eye surgeon is also in the audience. So look for the visual acuity and especially look for diplopia. So normally when there's a zygoma fracture, zygoma is the main bone creating the orbital flow. If there's a zygoma fracture, normally it is involving orbital flow, and there can be muscle entrapments, and also look for diplopia. And if you see the oral cavity, obviously these kind of mouths you will see after trauma. So they might tell you that my bite is not correct. So when I bite, it is not the usual way. There's some difference. So we call it a malocclusion. And they might have loose teeth or missing teeth and fractured teeth like in this photo. And you will have steps, and you will have lacerations and bleedings and hematomas and whatnot. And do a neurological examination, obviously for the infraorbital nerve as well as the mental nerve. If there's a paresthesia or anesthesia in the infraorbital area, so obviously it's a sign of zygoma fracture. And if there's a sensory loss or paresthesia in the mental region, it is a sign of mandible fracture. So I thought of telling something about this because in Sri Lankan context, it is a sad thing. It is a very much underreported phenomenon. white-eyed blowout fracture. So in UK, when I was doing my fellowship, I've seen multiple cases of this because they know how to identify this, and it is not going unrecognized. So but in Sri Lanka, sad to say, very few cases I've seen being managed. I don't know how the experience of the eye surgeon here, but that's the case of me. So this white-eyed blowout fracture is a thing happening to pediatric patients when they get a trauma to their eye or the orbit, especially when there's a special like a ball or something hit to their eye like that. So when it's hit, the pressure inside the globe or the eye orbit increases, so obviously it is going to fracture somewhere. Though the fracture should be there in the thinnest bone part, which is the medial bone or the floor. So it is going to fracture. So if it is happening in adult, it is not a problem because their bone is not very elastic. So it will fracture and the orbital contents will herniate into the maxillary sinus, so that's done. But in children, when that fracture occurs, you know this green stick theory. So their bone is not fragile, so it is elastic. So it fractures, go down, so the contents of the orbit can herniate, and then that bony part can snap back. So that we call the trap door. So it can trap in between that door, the bony pieces. So it can entrap the inferior rectus muscle specially. So when the inferior rectus muscle and these orbital contents being stimulated, these patients will be in enormous pain, and they will have oculocardiac reflex, so they will have bradycardia, and they will feel vomitish, and they will complain of a diplopia. So when a person come to A&E and tell, I have diplopia, I have vomiting, and I have pain in my eye, and those features, what would a medical officer or a doctor in A&E would do? Mostly they will monitor for head injury. That's what they do. Or else they will under a CT scan for a head injury. So silently these things will be missed. So that is due to this white-eyed blowout fracture. It is a one thing, head injury, obviously it should not be missed, but this is also one thing you should not miss. So this is one instance maxillofacial surgeon is being called immediately. So we can save their inferior rectus and their vision properly immediately in the theater. So we can just release that muscle, that's it. So please think about it when you see a boy or a girl with eye pain, refusing to open their eye, vomitish in their knee. Okay, what to do radiologically? I know we don't have CT scans, so I'm not going to talk about much about CT scans. It is the gold standard. But, so we can do something with occipitomental view or the OM view. If you suspect some middle face injuries like the zygoma maxilla or the frontal sinus fractures, so just take OM view or occipitomental view. And if you suspect some mandible fractures, take a reverse tower view. Any guess? Blast. Yeah, good guess. So this is the classic appearance. They search for this honey, bee honey. So obviously bears are being fond of bee honey, so they mate each other, and this is how when bear attacks. So just to show you one case when I was a senior registrar in Kandy. So he had multiple facial injuries with soft tissue injuries. So we did the plating, the zygoma and the maxilla has been plated, and then the soft tissue managed. So not perfect, but we managed to do something for this patient. Okay. Being oncological surgeon, nothing to be proud of. Oral cancer is the #1 or the commonest cancer in Sri Lanka among males. 3 people die each day. So it is nothing to be proud of for me to tell that we are the people managing oral cancer, because something is failing, something is utterly failing. Why? So these patients present to us in the late stages. Unfortunate situation is oral cavity is very accessible. Anybody with a torch can identify oral cancer, or a light or something. If you see the mouth, oral cancer is hardly being missed. So it is abnormal. Anyone can identify an abnormal lesion inside the mouth. So it is very sad. So if you see the survival rates, if you get a T1 lesion, less than 2 centimeter lesion, we can almost cure them. So the 5-year survival is more than 90%. If you get T4 lesions, the 5-year survival is less than 20%. So they die quickly. So overall, when I was a registrar, I did about 4,500 cases survey in Karapitiya. So our survival data was almost like 50% 5-year survival rate. So 50% of them died in 5 years time. So, and it is not a very peaceful death as well, because the cancer is in the most sensitive area of your body, and they have been isolated not to face, and then they can't eat or drink and smell and everything. It is not very nice. Okay, so these are the people we get. So each and every patient we operated, we did something. So, okay, how to identify a oral cancer? How? So if somebody tell you that this ulcer is not healing for more than 2 weeks, there's something wrong. So some person might tell you that these cancers are painless, but I've seen enough cases of cancers are painful. So it is not a very good sign. So you all know in the basic pathology how malignant ulcers looks like. These margins are elevated and inverted. There's a central necrosis and bleeding, and there's a classic odor. So when you see non-healing ulcer for 2 weeks, and look for induration. So if you palpate that ulcer, you might feel little bit firmer, and it is not being able to move from the underlying tissue. So it is called the induration. So look for induration, look for bleeding, look for margins elevated, and send them to us, please. So what we do for oral cancer? Normally we do diagnose them with incisional biopsy, sending for the histopathology, and then we do the staging with the CT scan, and we do multidisciplinary team meetings with the oncologist and all the other people. Not here yet, but I will try to do that. And stage 1 and 2 we do surgery. Stage 3 and 4 are combination therapy. Okay, so we cut the cancers. Obviously those kind of cheek cancers. So the first patient I've shown you. So this same patient I'm showing you. So this one. So we resected. As you can see, the resection involving cheek, buccal mucosa, mandible half, and lots of being dissected. So in the oral cancer, the nodal involvement is there. So we do neck dissection. So we need to remove all the lymphatics or the fibrofatty tissues in the half of that neck, preserving all the important structures. And obviously when you cut a cancer in the head and neck that big, you can't go send them like that. So you can't stitch them together. So we need to reconstruct it. So this case we have reconstructed it with a regional flap called pectoralis major myocutaneous flap, PMMC. So we took some tissue from his chest, based on the thoracoacromion artery, we have to tunnel it through the neck and put it to the cheek to fill the gap. Not very ideal reconstruction, but manageable for the patient's age and the other comorbidities. So this is the same patient after 6 weeks. So you can clearly see the reconstruction that area with the PMMC flap, and you can see how the flap came through the neck. There's a big plump of muscle, that is the pectoral muscle. And what about free flaps? So that was a regional flap. So regional flaps, what we do is we take the tissue from the region like the chest or the back with the latissimus dorsi flap. So we just take the same blood supply and we tunnel the flap to the head and neck. It is not ideal but manageable in Sri Lankan setup. But nowadays what we do is we do free flaps. So little bit of boasting. Free flaps are started by maxfac surgeons in this country back in 1997. And I was fortunate to be trained in locally and internationally to become a reconstructive microvascular surgeon. So I've trained in Peradeniya as well, and I've trained in Edinburgh to do a microvascular reconstruction. So free flaps are a reconstructive surgical technique we use to repair larger defects. With the advantage is we can take large pieces of tissue, and those tissues can be same as look like same in the recipient area. So the functional and aesthetic reconstruction will be there. So the patients will be more benefited. So we do it for selected cases because of the time constraints. So most of the cases will take more than 12 hours for one case. So just to show you one case of mine. So this patient is a 39-year-old male, came to me with a lip cancer. So lower lip is being resected, as you can see. 39-year-old. So it is like almost like my age. So I was being little sympathetic towards him. So you know, to reconstruct the lower lip, it should be very pliable, nice tissue, and the lip is the input to the oral cavity, so it should be functional as well. So to talk, to eat and drink, and the aesthetics. So we decided to do something called this radial forearm free flap. So tissue was harvested from his forearm based on the radial artery and the vena comitaensis. So you can see the flap markings in the first picture, and the second picture me dissecting the flap out with the radial artery and the vena comitaensis. And here you can see the radial forearm free flap is being inset to the donor side, to the recipient side, and it is there. And you know, these kind of cancer, when we obviously do a neck dissection. So obviously the neck dissection is being done and the vessels are being prepared. So what we do afterwards is the microvascular anastomosis. So radial artery is being anastomosed to the radial artery, and the vena comitaensis is being anastomosed to the internal jugular vein. So the blood supply is there from the neck, so the flap can survive. So after 3 months, this is the patient. So you can see the reconstruction from this to that. You can see it is aesthetic and it is functional, and he was very happy. So we can do magic with free flaps. And is it only soft tissue? No, we can do hard tissue as well. So if we were to remove patient's jaw, the mandible, the maxilla, we can replace it with living bone. So in the first picture you can see we have removed half of the patient's mandible. I don't know whether it's clear. Yeah. So half of the mandible is being removed. So bone should be there. So we harvested something called the fibula free flap based on the peroneal artery and the vena comitaensis. And so this case we have done virtual surgical planning. So the surgery is planned in the computer with the software, and the cutting guides are being done. You can see in the first picture we are shaping the bone according to the jaw shape, and second one you can see the bone is being plated, and the third picture is patient after 2 weeks. So it is half the jaw removed, but his function and aesthetic is there, so he can have dental implants later and he can have teeth. Okay, that's about cancer and reconstruction. Okay, so we do salivary gland surgery as well. So since the salivary glands are in the head and neck region, obviously when somebody is coming to us with tumors of salivary glands, cysts, cellulits, ductal issues and all others, we do surgery for the salivary glands. Okay, being plastic surgeons. So what is the plastic surgery we do? So this patient came to me when I was in Ragama, soon after my foreign training. So his parotidectomy was done in 2020. Radical parotidectomy together with the facial nerve. So his face is asymmetric, his smile is not there, oral competence is gone, cannot close his eye. So he was wearing a face mask all the time. So he was asking me to do something. So we can do facial reanimation in lot of ways. So I've done the simplest way for him, called the temporalis flap. So the temporalis flap is the temporalis muscle, you know, it is here. So it is, so I have dissected that muscle through the mouth and took some fasciolata from his thigh, and it is being tunneled here, and the temporalis muscle is being joined to his lower lip. So when he clenches, if he bites, you know, the temporalis muscle is going to raise, so his corner of the mouth can go up. So that is the simplest technique of doing it. So he need to learn how to smile. So when he is smiling from the other side, he need to clench. So he need to learn that. It is obviously not a emotional smile, but I think this is okay for the first day. So this is just 24 hours after the surgery, he learned how to do that. And he was very happy. You can see even the skin color has been changed. So he was very happy. So we can do those kind of things, but there are very advanced techniques of facial reanimation. So, but these simple techniques also working. And cleft lip and palate. Cleft lip and palate is the most common congenital anomaly in the head and neck region, and it is being managed with multidisciplinary team, and MaxVax surgeons are doing the 2/3 or more than 2/3 of the cleft burden in Sri Lanka. So we do repair the cleft in 3 months, cleft lip in 3 months, palate in the 1 year of age, and we do velopharyngeal insufficiency or the speech correction in about 4 years time, and we do distraction osteogenesis to correct their jaw sizes in after like puberty, and we do correct their noses after 20 years. So it is a journey of 20 years with a multidisciplinary team, lots of people involved, pediatricians, orthodontists, the speech therapists and ENT surgeons, and speech and language therapists, and lots of people are involved in this management. So it is a 20 years of journey. Just to showcase one case, so this child is having a wide unilateral cleft lip and palate. So we corrected it. So this is how it is being corrected on the table, and you can appreciate how much of discrepancy is there in the first picture and the second picture, the anteroposterior discrepancy, and the same child after it is being ready to go home the following day. So these are life-changing surgeries and very sensitive things. So we can establish this kind of surgery in this hospital if our specialty is being established here. And just to tell you about orthognathic surgery. So orthognathic surgery is a surgical procedure to correct people's shape of the face. So if somebody is not happy about their shape of the face, if somebody is thinking their lower jaw is big or small, or their upper jaw is big or small, if it is there's an asymmetry of the smile, and when you are smiling your teeth looks more, or teeth are very much forwarded, so we can correct it. So it is a combination of orthodontist. So since the orthodontist is in the audience as well, I am telling this more. So it is a combined treatment with orthodontists. So orthodontics. So you might wonder what orthodontists do and why there's a surgeon here. So orthodontics, in the orthodontics, I would say the orthodontists might agree with me. So they do malocclusion correction at the dentoalveolar level, at the teeth level. So they can correct, they can move teeth around and they can correct their malocclusion at the teeth level. But if the malocclusion is beyond the teeth and if it is coming to their jaw bones, then obviously a surgeon should come. So just to show, so nowadays we do virtual surgical planning. So I was fortunate to do the first ever virtual surgically planned orthodontic surgery in Sri Lanka. So nowadays we do the CT and we can plan that surgery in the software, on the software, and we can predict that surgery and we can create surgical cutting guides and we can print the plates, 3D print. So that surgery is precise and there's no way of something going wrong. So we can show the patient beforehand the surgery, this is what you are going to become. We can show them. Few cases of orthodontic surgery. So this man or a boy, see, came to see me at Ragama and he was not happy about his lower jaw. It is been little forward, so he was telling me that my look is like Batakolachi. That is his exact words. So Batakolachi type. He was not happy, but it is been considered as beautiful at some of the communities, but it is all subjective. If the patient tells me that it is not beautiful, so it is the case. So it is, we have done something called bilateral sagittal split osteotomy and we have pushed his mandible back. So this is 24 hours after the surgery, so his jaws was, the prominence is being reduced, so he was very happy. And some other people like this come to us. So obviously she couldn't close her mouth. She was having very much hardships of eating and drinking, procline teeth, and social isolation, wearing always wearing a mask, and not going to work, not going to school after grade 10. So then she requested me to do something. So orthodontist and me discussed, but because of her urgency we decided to do something called this surgery first approach. So we did mobilize her maxilla with Lefort 1 level osteotomy and we pushed it up and back. So this is her after 2 weeks. So she was very thankful, so she could close her mouth and she could smile. So I don't know whether you recognize, it can be seen in her eyes as well. So the first case he was not even looking at the camera, but the second case after the surgery he was very happy. This one is a virtually planned case. So you can see in the first picture asymmetric face, and the second picture you can see maxilla is little bit backward and mandible is little bit forward, same thing. And the fourth picture you can see when she's smiling her lower teeth is not visible and the mandible is little bit towards the left side. So this is her after 1 month of surgery. So you can see in the second picture especially her maxilla and the mandible is being corrected and the smile is being now symmetric, there's no asymmetry and her smile is better. So she was very happy. And if somebody is interested in teeth, so this is how she came to us, and this is how she went back. So her bite is being changed dramatically. Okay, so what is craniofacial surgery? So we do something called craniofacial surgery when there's syndromic conditions like Cruson syndrome, Apert syndrome, Treacher Collin, Pierre Robbins, and Goldena. These children come into us, so we can do surgery to correct their hypertelorism, their reduce mandibles, and to correct their airways. We can do distraction, osteogenesis, and the other surgeries to correct them. So still, since I'm a budding surgeon, I don't have my own cases. That's why I'm not putting somebody else's cases. So all these cases are mine. So I'm not putting any cases because still I have not done my own cases. Right. So being oral physician, I think this part is important. So we get oral mucosal conditions. We get dermatological conditions like lichen planus and pemphigus, pemphigoid, and those kind of cases affecting oral cavity. And we get fungal and viral infections. There's a group of disorders called oral potentially malignant disorders, and we get temporomandibular joint problems, and we get facial pain conditions like trigeminal neuralgia, atypical facial pain, and so on and so forth. So I'm trying to emphasize more on this part because this is very important. Oral potentially malignant disorders are a group of clinical conditions in the oral mucosa that carries a statistically significant increased risk of developing oral cancer. So to tell you, 80% of the oral cancer cases in Sri Lanka originate from an existing OPMD. So what are these? So especially I would like to emphasize on this condition, oral submucous fibrosis. It is mainly, not mainly, it is almost all, like 100% is due to erica nut beetle quid chewing. So these people will come to you and tell you, my mouth is burning when I eat spicy food, and my mouth opening is restricted, and I feel like leather inside my mouth. My mouth is no more soft. So this is called submucous fibrosis. It is entirely a clinical diagnosis, and they have 7 to 19% of malignant transformation rate. So they are going to have a cancer in the future. So please, when you see these kind of patients with pale, leathery oral mucosa with burning mouth and restricted mouth opening, call us, send to us. And leukoplakia, I think almost all of this audience know about it. So when you have a white patch which cannot be rubbed off, you cannot attribute that to any other disease condition. So this is leukoplakia, and it is going to be malignant transformed in 1.5 to 34%. So if you see a leukoplakia, also refer them to us. And erythroplakia, that is the dangerous, most dangerous one. Red is dangerous. So the same thing, red patch inside the mouth, you can't attribute it to a trauma or anything. So this carries malignant transformation rate of 85%. So it is almost like cancer. Please refer. And oral lichen planus, I think it is almost all of you know this. So when you see a patient with lace like this Wickham lines inside the mouth, some reddish areas, they might complain you some burning sensation. So it is carrying nearly 2% of malignant transformation rate. Please refer. And oral surgery, finally, what we do inside the mouth. So I think most of this audience might have had some problems with their wisdom teeth. So when you have wisdom teeth which is refusing to come in the proper way, they come in different directions. So if they give trouble, we can remove them for you. And if you lose your teeth, we can give them permanently with titanium dental implants, as well as if you become very old and if you lose each and every teeth, and there's no way of doing a dental implant, we can do something called zygomatic implants. We can do implants to the zygoma and give you permanent teeth at your 90s and 100s. And odontogenic cysts and tumors, lots of odontogenic cysts and tumors are occurring in the mandible and the maxilla due to odontogenic epithelium trapped inside the jawbone. So these cysts we can manage, we can remove them, and we get vascular lesions inside the mouth. Okay, so we get vascular lesions inside the mouth. So these things we can manage. So if you see them, send to us. Okay, I think that's all I'm going to tell you. And so since I've seen this video inside in the internet, because I've seen lots of people pronouncing and telling our speciality's name in different ways, so I was thinking like it is not only in Sri Lanka, it is happening elsewhere as well.
I went to an oral surgeon.
My facial surgeon did a great job.
I had to see an oral and facial surgeon.
My dentist sent me to an oral and maximal.
Maximus. Maximus. An oral and maxillary surgeon, or something like that.
Officially, we're called oral and maxillofacial surgeons, and we're the experts in face, mouth, and jaw surgery. Members of the American Association of Oral and Maxillofacial Surgeons are trained and experienced in all these treatment areas. Our work saves lives, changes lives, and makes lives better.
I'm not sure what to call him exactly. I just know he did a great job with my dental implants.
She cured my sleep apnea.
He fixed my recessive jaw.
Diagnosed my oral cancer in time to beat it.
Took out my impacted wisdom teeth.
What you call us isn't really important, but when you're concerned about health issues related to your face, mouth, or jaw, just make sure you call us.
Why does everyone have such a hard time saying oral and maxillofacial surgeon? Really?
Really? Okay, thank you. Thank you, Mahiyanganaya Clinical Society, especially Dr. Prabhash and Kaushal and everyone for giving me this opportunity, and thank you everyone for coming here. And let's establish this unity in our hospital. Please help me. Thank you. Any questions? Yeah.
Forensic odontology, is it the OMFS surgeons become forensic odontologists, or is it some separate pathway to become forensic odontologist?
Still there's no proper pathway of becoming a forensic odontologist. So it is like merely an academic thing. So university attach people and become that. And I know that PGIM is trying to establish the course, and there's lots of other time constraints and all is there, but forensic odontology is completely different thing. So but since for the time being there's no specialists for that that category, so that's why we are trying to help you with these kids and all, with these eruption times and all. So there's no speciality as such in Sri Lanka. Yeah, you can call me, but the problem is I might have to get other experts help for that. So I might be able to help you at some extent, but not everything. Thanks. Is it stuck? Yeah. Yeah, please.
This is specifically for the pediatric and the emergency people and surgery teams, because whenever you have this
white ball eye fracture, a lot of time we have seen that it's a mismanaged. So yes, because you won't see anything because of eye is totally white. That's the problem. So specifically, whenever the patient gives history to the head injury without orbit, because most specifically after blunt injury, most of the trauma straight away towards the inferior owl. You all can see this because there is nothing in the eyes, so almost all of them will miss. So here two things we have to consider. One is life threatening, other one is a sight threatening. So those two are very important. So as Sankalpa mentioned, first thing is a life threatening. That is important thing is the oculocardiac reflex. So I think you all know why there is oculocardiac reflex in this important. Anybody, why they develop the oculocardiac reflex after a blunt injury to the eye? Eye never ever related to the heart, so why is that? Anybody? No, I'm sorry. Because vasovagal tips, that's why. No idea. That's the eye is never straight away connected to the heart, but it's still you all get the oculocardiac reflex. Because in Sri Lanka they have mentioned the death, especially in the pediatric period. Why? Because the eye muscles are supplied from the the extraocular, the third, fourth, and the sixth, and the problem is this mandibular nerve. It extends from the inferior level of extension is spinal cord, upper part is at brainstem, on the midbrain at the level. So it connects all the fibers. It has the connection with the vagus and these three nerves. That's why whenever these nerves get stimulated, it is indicates this trigeminal nerve. Okay, so that's where the connection is begins. That's why the vasovagal attack is begins even after an eye injury. So that's most important, because these deaths are occurred in rural areas. So I don't want to mention the areas, and that's the very important. Then second thing is the vision threatening. So the sorry to mention other one, especially pediatric group, you will miss this oculocardiac reflex. Why? They already have the pulse rate is high. Around the pediatrician here mostly agree with me. Until 16, even 120 is considered as a normal sometimes. Okay, so that's the problem. Even a 10 years old boy, if he presented pulse rate is around 80, please think about it, because they may have the normal. So please look for the previous document. Recently they have the pulse rate documented or not, that thing. So therefore almost always be aware about the oculocardiac reflex. You can prevent a life with that. Second thing is the life threatening. So whatever the thing, always check for the RAPD. If it is there, please immediately refer. That is second thing. So those are the things I wanted to add in this, and I think this was an excellent lecture done by the Sankalpa, and the most of the juniors will follow him after this. Thank you.
Anything else? Anything else to ask me? Yeah, thank you. Yes. Yes, cleft lip, cleft palate. So I've been working in two, as you know, Sri Lanka, they have 3 cleft centers. One is in Karapitiya, one is in LRH, one is in Peradeniya. So those are the only 3 hospitals we have the complete multidisciplinary team, and it has been going for like long time. So in Karapitiya, what they are following is the natural way. They always encourage breastfeeding. Try to establish that and monitor with the child's growth and the weight increase. And if it is like, if the pediatrician and the other specialists think that it is been underfed or something, only they will advise for cup feeding or the juice bottle feeding, that bottle with the spoon. And there's some teeth called the orthodontic teeth with a bigger hole, so that teeth also can be used. So otherwise the natural way, the breastfeeding. So they advise to put the mother's breast as such that that breast can cover the area where the defect is. So the mother can help with the child with that. So then they obviously are very healthy babies other than the cleft lip. So they will try and they will learn how to do it. So the natural way we encourage mostly. Yes. Suckling. Little early. Anything else? Cool. Okay, thank you. Thank you so much.
Thank you very much.